It's Friday, April 11th, 2025. This is the Room Now podcast. Hi, I'm Jack Cush with RoomNow.com. A lot of interesting things this week. Reports from Korea, reports on infection, reports on ANCA-associated vasculitis, and, of course, what are we going to do about cannabis? Let's lead with, I think, the thing that's most on your mind these days. Why am I getting so many GD messages on my EHR? I've heard this over and over from a lot of my colleagues. It's kind of like become a major part of their work day. It was enough that, to see the patients, to write the notes, to review the labs, to go through all the things that were patient related, whatever. But now to spend more time on the EHR dealing with a myriad of questions is a real big burden. And we know that the EHR is like the primary culprit in burnout. So an interesting report this week that looked at Epic EHR data. This comes from you and everybody else that uses Epic, spelled EPIC, not EPOCH, which is what I thought when we started because it took forever to get going. Anyway, enough about that. They looked at messaging, and there was a clear-cut increase in messaging from patients on Epic, starting with the pandemic, and it has remained elevated since the pandemic. And interestingly, while that went up significantly, there was no change in other means of patient communication, mainly phone calls, but other written messages, etc. At the same time this is going on, the amount of time that physicians are spending on their EHR has gone up significantly and remained elevated for pretty much all medical subspecialties post-COVID-19. It went up 6.5% for primary care, almost 10% for subspecialists, and 5% for surgeons. And the question is this the new normal, or are you going to do something about it? I think when I don't like the behavior of patients, I like to blame myself, because that means I haven't educated my patients on what the right behavior is. Nobody knows how to be a patient. Nobody wants to be a patient. Nobody wants to be sick. Nobody wants to have to write an email or a message to their doctor about, do I take 2 or 3 green ones a day, or should I quit it and just take pot? Crazy questions that make no sense. Well, you have the responsibility of training your patients on how to communicate and what to communicate about. So that's my first suggestion. It's up to you. Set the rules, write them out, hand them to the patients, send me messages about A, B, C, D, and F. Really important. Don't send me messages about 1, 2, 3, 4, and 5. We can discuss that at next visit. So see how that works. It's somewhat dissatisfying. I must say, I used to tell my patients, I'm going to review your labs when they come back this week, and if I don't call you, that means everything is good. That doesn't work. Patients kind of want to know what their labs are. Why they need to know what their chloride levels are, I don't know. But again, as I've written about in the past, patients think labs are the official arbiters of health. And if that's so, again, that's your not educating them. So work on this, otherwise it's going to continue to plague you. 2 interesting studies from Korea, a claim study from 2008 to 2021 on 183,000 patients with both psoriasis and psoriatic arthritis, compared being on a biologic to not being on a biologic using phototherapy as the comparator. And it showed that if you were on a biologic, you had a significantly lower risk of new onset or recurrent major adverse cardiac events, aka MACE. Turns out that this was also seen with non-biologic systemic therapies, meaning methotrexate, lowered MACE risk, but only in people with a prior history of MACE risk. So it looks like biologics are probably better than methotrexate in lowering that risk, and it makes sense, as we know, because if you lower systemic inflammation, risk of cardiovascular events, MACE events goes down significantly. A study from Korea also, with Jeff Sparks in there as an author, looked at their KORAIL, K-O-R-A-I-L, that's the Korean RAILD prospective cohort study that they looked at biomarkers, usual assessments, and CT scans for outcomes. And they showed in this cohort, followed over time, fairly large, 35% of them had progression of their ILD within a 3-year period. That the biomarkers that we should be doing in rheumatology that our pulmonary colleagues are doing all the time, mainly KL6, it's available in commercial labs, was significantly higher at baseline, as was heat shock proteins D, HSPD, about half the patients elevated at baseline and associated with progression. Mainly increases in KL6 at 1 year showed the greatest change in overall progression of their RA-ILD as measured by CT scans. Those who were in the upper levels of change with KL6 had a twofold higher risk of progression in 1 year. So again, the point here is KL6 is a new measure that should be probably done in following people with chronic ILD. And this is a study of RA, but I think it probably applies to other ILDs as well. The FDA approved a new drug this week, Ablinza from Amgen. It's Inebilizumab. It's an anti-CD9 monoclonal antibody meant to target B cells, CD19 I said, meant to target B cells. It's the first approved therapy for IgG4-related disease. It is the IgG4-related disease is estimated to affect 20,000 people in America. This is obviously not going to be first-line therapy because the price of it is over $140,000 per dose. And you give 2 initial loading doses and then Q6 months after this. So this is very expensive therapy, but it's been shown to be effective. We reported that in a New England Journal article. I think it was last quarter of 24. And you should know about this. This Inebilizumab is approved now for IgG4 disease, also approved for neuromyelitis optica. Another approval. Another report this week on the same drug, Inebilizumab, and its use in myasthenia gravis. It's not approved. This was a phase 3 clinical trial result of 3,200 patients showing significant improvement in function and reduced disease severity only in the patients who were antibody positive, either had the anti-acetylcholinesterase receptor, acetylcholine receptor antibody, or muscle-specific kinase antibody positivity as markers for myasthenia gravis and inclusion into this study, or certainly those are the ones that had the best responses. A really important, I think, good reference that you should download or read from JAMA, a full review on Staph aureus and Staph aureus bacteremia. As you know, it's a big problem. It's dangerous. All those people are symptomatic with fever and systemic illness. A third of them will develop systemic infections, metastatic infections, and led by endocarditis at 12%, but arthritis 7%, osteomyelitis, vertebral osteolytis about 4%. Turns out if you've got bacteremia for more than 2 days, you have a 39% mortality in the first 90 days. All these people are febrile, and I put this up because as much as endocarditis is the main thing we think about, osteoarticular manifestations of bacteremia with Staph aureus, 14%. So you should be knowledgeable and aware. Interesting study of childhood SLE, pediatric SLE, which you know is usually much more severe than adults. This is a cohort of 185 patients looking at long-term outcomes, and 20% of them had serositis. That's not really surprising. But what is surprising is that serositis in pediatric SLE is associated with worse disease. It happens in younger patients. It happens to be associated with more disease activity, a higher degree of comorbidities, and higher mortality rates. Specifically, if the child has serositis and end-stage renal disease, that the 20-year survival is really poor. Now, that sounds like the surprising part is the serositis. End-stage renal disease sounds like it would be a risk factor already, but serositis adds to that risk. So it should be something that you should stow away as this is a even more severe patient if serositis is in play. A study of ANCA-associated vasculitis comes from the Danish registry on ANCA-associated vasculitis, 1,400 patients, median age 69, half male, half female, follow-up about 5 years. Cardiac manifestations associated with ANCA-associated vasculitis. Now, remember, the median age here was 69, so I think that taints some of what I'm going to tell you. But there was more LVH, 17 versus 12%, more STT elevations, AFib, QT prolongations. It sounds like it could be age, but I wasn't really that keen on cardiac complications of ANCA-associated vasculitis. It certainly is more prevalent in EGPA, less so with GPA. But anyway, it turns out in this study, only the patients who had ECG abnormalities, as I just described, were at increased risk, a twofold increased risk of cardiovascular mortality. So, again, maybe important, maybe not. You decide. The Apex study, a phase 3B study, was reported this week as a press release. This is a study of guselkumab versus placebo in biologic-naive psoriatic arthritis patients showing significant ACR20 improvement and significantly less X-ray progression compared to placebo at week 24. These are top-line results. They didn't give you good numbers. I think I put this out there for those of you who are looking for this data and know that it's probably going to be presented at either EULAR or ACR upcoming. A 12-month study, 2 studies this week in JAMA talk about the use of non-pharmacologic measures, and I talked about this last week. I think we should be paying attention to this. This is a 12-month, 770 patient study of those with chronic low back pain taking opioids, and they found that mindfulness-based therapy and cognitive behavioral therapy, CBD, they were both non-inferior, they were both effective, and they both significantly reduced opioid usage. The question I asked on the tweet is, why are we not using more mindfulness-based therapy and more CBD? CBT. CBD, that's another thing I'm coming to in a minute. And I think it really behooves you to go out there and find someone or a few people that do cognitive behavioral therapy in your community and start using them. I think it's smart. I have a friend who likes to tease me all the time about, what is it with you doctors and your prescriptions? Why aren't you using other forms, non-pharmacologic, natural things, whatever. And I think we should be thinking about these things because they are adjunctive and they are generally well received by the community, the patients who need them most. Another report in JAMA looked at compared yoga versus strengthening exercise in patients with chronic knee OA. And it was like 117 patients or something like that. And again, they were non-inferior to each other. They both showed improvement. In a quarter of the measures, yoga was superior to strengthening alone. So I do recommend, leg strengthening for knee OA. It helps to maybe keep them away from surgery. It helps with their symptoms. But yoga can do the same. And maybe, again, well received. I don't really believe a lot of my patients are running out and doing the leg strengthening exercise I ask them to do, whether it's bicycling or pool or isometric quadriceps strengthening exercises. I'm going to end with ACP came out with guidelines published in Annals of Internal Medicine this week, best practices on cannabis and cannabinoid use for non-cancer pain management. I believe that this is a useful adjunct. I've complained that there are no guidelines because the best guidance on the use of cannabinoids or cancer comes from some guy named Paco behind the counter at the dispensary. And he's saying all kinds of goofy things. So anyway, at least the ACP has jumped into this. It's a reasonable thing to look at. It looks at the harms and the benefits and the level of evidence that's out there. They came up with 4 statements. Best practice. 1A says counsel patients regarding the benefits and harms of starting or continuing cannabis or cannabinoids for chronic non-cancer pain. best practice advice 1B, that you should counsel certain groups of patients that the harms may outweigh the benefits. Specifically, they're concerned about young adults, adolescents, those with substance abuse disorders, those with mental illness that's not well controlled, and frail patients and those who are at risk of falling. Best practice advice number 2, avoid these drugs for non-cancer pain in women who are breastfeeding, pregnant, or actively trying to conceive. And the last advice is advise patients against the use of inhaled cannabis to manage chronic non-cancer pain. If you read the article, I didn't write down why, and as I was putting this together, I thought, well, why they got a thing about inhaled weed, which is what most of the use really is, right? And the article goes into this saying a few things. One, that there are no good studies to really discuss to confirm its value. 2, that there are hazards to inhaled cannabis that are akin to inhaled tobacco. 3, the risk of bronchitis is real with inhaled cannabis, and they are particularly worried about older adults with established lung disease being poor candidates for inhaled cannabinoids. And then there was a line in there about there are no studies about a potential for COPD risk with chronic use of inhaled cannabinoids. So it's better to go to the dispensary and spend more money probably and have to endure the advice of Paco than to meet in a dark alley and buy a bag of weed from Paco's cousin, Ernesto. I don't know why I'm calling him these names. I'm just making this up. But I think you get my point. That's it for the podcast this week. You can go to the website, check out these citations and the links. I want to remind you that if you weren't Room Now Live, it is available on demand, over 20 lectures, over 12 TED Talks, all the downloads, all the learning, really high quality stuff. I would encourage you to tell your friends about it. 2 things coming up on Room Now. One is maybe in 2 weeks or 1 week or so, we're going to start with something called Room IQ. We're going to invite you to participate in a weekly quiz of last week's news. And it's a quick way of learning what you may have missed. I think you'll find it fun, interesting, and useful. And the other thing is that in the month of May, we're going to have a month-long campaign on lupus. We're developing the content right now. I think you're going to like it. It's really interesting to me in developing. I think you're going to like the content that comes across your inbox and also on the podcast. We'll talk next week. Take good care.